Good morning, everyone. And we would like to welcome you to the second day of this conference, all of us. And we are praying that you will have a very fruitful and informative and productive gathering with us today. Let us go to the throne of grace. I have only just a minute, only 60 seconds in it. Forced upon me, can't refuse it. Didn't seek it, didn't choose it. But it's up to me to use it. I must suffer if I lose it. Give account if I abuse it. Just a tiny little minute. But eternity is in it. Eternal God, our Father, we thank you. We thank you for this opportunity to come together, to fellowship, to impart wisdom and knowledge, and to inspire our community to be stronger together as we move forward to face the challenges of the future. Lord, just bless us with your presence, bless us with your power, bless us with your wisdom. And through it all, we will give you all the praise. Lord, hear our prayer. We ask it all in Jesus' name. Amen.
Greetings and good morning to Dr. Watson, NIH, and other members of that organization, to Dr. Sodake and other members of this planning group and the committee, to our visiting guests from outside of Macon County and our residents and community leaders of Macon County, and all constituents who contribute to this important mission of advancing health equity. Thank you for being here. Your engagement of this cause and your commitment to eliminating the disparities that we all know well is critical. And it's important that we all play a critical role in resolving them. On behalf of President Charlotte Morris, we at Tuskegee University, and with our rich history, know all too well regarding the health disparities and how efforts to study and impact the way diseases can devastate a community of people. Yet, the resilience of Tuskegee University continues to overcome the historical challenges of prejudice and has contributed to the many solutions in healthcare, advancements of yesterday as well as today. Not just the study to eradicate polio, but advancements that address cancer and other health ailments in our society, research that continues on this campus this day. The Tuskegee University community thanks the All of Us research program, and we're happy to play a significant role in research, policies that address bioethics, and healthy living practices as well, to improve everyone's quality of life. We look forward to exploring more innovative ways of collaboration and partnerships with NIH and other federal and state agencies to address these challenges of health equity and the well-being of all communities, Black and brown, and those that are underserved. On behalf of President Morris and the whole Tuskegee University family, thank you and have a great second day of this symposium. Thank you.
Good morning. My name is Channa Prakash. I'm the Dean of the College of Arts and Sciences at Tuskegee University, where I have been proudly serving this great institution for the last 33 years. and I've been a professor, and now as a dean, overseeing both the science, the arts, and the history departments of our university. I'm very uniquely situated to understand the tremendous contribution our university has made in the town and gown. And this is one good example as to how the experts at our university, led by Dr. Sodeke, have come here to work with the active members of the town in trying to enhance the quality of life of all citizens here at Tuskegee and at Macon County and across the Black Belt. And a few things that come to my mind as to how we have played, our professors have played a critical role in advancing the health. Dr. Hargrove mentioned the polio. The first polio vaccine was multiplied here at Tuskegee University using the HeLa cells, which you all know has become somewhat controversial, but nevertheless played a very crucial role in helping with the health of all people around the world. And the very first experiment was done here at Tuskegee University. And the polio vaccine, before that, the Polio Foundation was started here by Basil O'Connor, who was the chairman of the Board of Trustees here at Tuskegee University, and we have recently erected a very beautiful monument. And those of you from outside, Dr. Watson, I hope you'll have a chance to see this very incredible monument that we have put recently at Tuskegee University. So advancing the health and advancing the nutrition, the diet, and helping the farmers here, we've always been very well known since the time of George Washington Carver, but also in the economic and social justice issues around here. Our professors have played a tremendous role. Charles Gomillion helped fight the imbalanced district mapping, the electoral mapping for the first time to uphold the 15th Amendment. And many of our professors today in biomedical research are not only doing cutting-edge work in trying to identify disease markers and trying to help develop a cure, but are also very actively involved in working in the community to provide a science-based awareness of issues such as vaccine, HIV, and so on. And again, I'm delighted about this event today, and I wish you much success as you move forward. Thank you.
Good morning. Good morning. Welcome to day 2 of the Macon County Health Research Symposium, sponsored by the All of Us Research Program, the Southern Network, and Tuskegee University. My name is Dr. Stephen Olufemi Sodeke. I serve as resident bioethicist and professor of bioethics within the Center for Biomedical Research at Tuskegee University, and I'm also the site principal investigator for the All of Us Research Program. And to use the football analogy, I am the privileged quarterback at Tuskegee for the All of Us Research Program community engagement. It is with gratitude to God and humility that I stand before you this morning in this sacred place and on this hallowed ground to declare to you from the Word of God that we are all God's masterpieces, created in Christ Jesus to do good work, which God Himself has prepared for us to do before time. I want to acknowledge my wife, who is somewhere in the audience, for her consistent support in many ways. And if I start to list them, we'll be here all day. And I know she wouldn't want me to do that. I also want to thank my other prayer partners locally, nationally, and internationally. Please, keep the prayer going. Earnest prayer works, and I am a witness. So it's with deep appreciation that I recognize today the foot soldiers, those in the trenches, working behind the scenes from our communities in Tuskegee, Birmingham, and other cities in our catchment areas, who serve passionately on the planning committee with PISIC's partners, the NIH representatives, to help bring to life this two-day program. I request the audience to hold their applause until I finish calling their names, and we will all applaud them together. From Tuskegee, Ms. Cheryl Ferguson, where are you? Over there. Ms. Cynthia Wilson, Councilwoman Norma Iyabode Jackson, where are you? Over there. Ms. Patricia Goulet, where are you? Over there. Dr. Lucinia Dawn, over there, and Ms. Bernice Frazier. From Birmingham, Ms. Sharon Hardy, where are you? Over there. Mrs. Edrica Miskel, over there, and Dr. Shantiz Allen. The planning committee did an outstanding job, so with gratitude, let us give them a round of applause. Thank you. I also want to thank everyone in the audience, particularly those that are with us in person and those that are joining online. And especially those of you who are in the Amen corner, for coming to bless us today with your presence. May God bless our time together. Somebody say amen. Amen. Okay, we can go on now. Now let me now take a moment to set the context of our time together this morning. Well, you know the news already because you are here. What we do not know is the rest of the story, because we are writing the story even as we speak and even as we convene here today. And for the purpose of this occasion, I will title the story, You Never Know Unless You Go, Moving Forward from Promises to Progress. This story will not, and I repeat, will not be complete without you. We will depend on you to help us tell your part of the story from this day and perhaps for generations to come. May I take a minute to share with you my part of the rest of the story? May I do that? Thank you. Now fasten your seatbelts then, because we are about to take off. So it's such an honor to host this event in partnership with my brother, Dr. Karim Watson. Dr. Watson and I wish to say to you, in the words of Joseph, Jacob's son, who said to his brothers when they met him in Egypt and could hardly recognize him, "Come closer. We are your brothers." It is for such a time as this that God sent us ahead of you. That's what we say. So my part of the story begins like this. Today is another special day of celebration. It is day 2 of the celebration because God simply made a way. He is a God that makes a way where there seems to be no way. So I'm full of joy today because we are in the process of making the invisible visible. We have been working hard. We are here to say we count. So we will dare to be counted among those who would change the future of health for all of us through breakthroughs in scientific research. And as you well know, February is Black History Month. We must take seriously the words of the Reverend Dr. Martin Luther King Jr., who said, "Of all forms of inequalities, injustice in healthcare is the most shocking and inhumane." Well, the time to act is actually now. We have the power to drive health research now for all of us and for generations to come. We are in this together. The students, faculty, staff, with the one Tuskegee spirit that we have come to identify with the era of our president, Dr. Charlotte Morris. Are you full of joy today? Thank you. Well, how did we get here? On May 6, 2018, I joined by invitation the likes of Dr. Selwyn Vickers, Dean UAB Medical School, Dr. Francis Collins, Director of NIH, and Dr. Dara Richardson Heron, then Chief Engagement Officer, to launch the All of Us research program in Birmingham. So as I was speaking from Birmingham, Dr. Francis and others were speaking from different locations across the nation, like Nashville, Tennessee, like New York City, Chicago, California. My 6-minute speech featured not obstacles or difficulties that we may encounter, but focused on promise that this NIH research program offered. The speech pondered the role of each one of us and the community in consultations and in taking advantage of the opportunities and initiatives that we must not just pass up. If we're serious about dismantling inequalities and ensuring health equity, not just for some people, but for all people. I reasoned that in order to take advantage of the opportunities, someone had to step up to the plate, because you never know unless you go. So I want to thank Dr. Bruce Cove, Dr. Mona Fuad, and Dr. Beth Lewis, the principal investigators for the Southern All of Us Network at the University of Alabama, Birmingham, for their consistent, continual support and encouragement during this journey. Thank you so much for letting us do this our way. So where are we going today? We're here to continue the writing of this story. So for this principled engagement of Tuskegee students, researchers, faculty, staff, and community members in consultation sessions, yes, we will address, if you will, the historical context of research and the needs to heal and establish trust. We will examine lessons learned from the past and highlight the practices now in place, but we will do more than that, because we want to be part of the solution. So today is also a day of call to action. We must get it right. We must get it right. We must move from promise to progress together. The important contribution we need from you during these day 2 convening sessions is to help us tell part of this story. The story of our looking back in order to move forward will not be complete without that contribution. Help us understand how, looking towards tomorrow, we might examine opportunities for collaborations between researchers and the community, designed to answer questions that are important to us as a people, and to ensure precision health, precision medicine that will improve our health. So to conclude, our purpose here today is to do 3 things. Number 1, acknowledge and address the historical context of research because of who we are, where we are, and have been, and the need for continual healing. Number 2, discuss the impact of our lived experiences on our being in research and the protections in place. Number 3, looking towards tomorrow, discuss and examine opportunities for collaborative work between researchers and our communities to address research questions that are of value to us. What has to change? What will and should, who will and should do what moving forward? So I want to express my sincere appreciation to our panelists for answering our call to work together at such a time as this. Let me encourage all of us present here today, whether you are joining us by satellite or you are in person here today, to write the story with us. And as you write this story, sit in victory if you are sitting. If you're standing, you stand in victory, because we serve a victorious God who gives us the victory we have in Jesus. And before I take my seat in victory, I want to recognize the excellent work of our cameramen and women, our videographers, our logistics persons working behind the scene to make this event a huge success. God bless you all, and let's give them a round of applause, please. Our moderator for the day, the first session of 3, is Mr. Chris Williams, my brother and friend. Mr. Williams is, I think I would just pass the talking stick to him and let him introduce himself, and then, Mr. Williams, take it away. Oh, my brother, sorry about that.
That's okay.
All right, very well, Dr. Watson.
Good morning, everyone. I won't be before you long. I just want to thank Dr. Sodeke and thank our panelists, and thank you all. And just, it's the right time, it's the right place, and we're gathered to do the right thing the right way. And I'll thank you all. I want to thank our colleagues from Pyxis Partners for helping to host and organize this event today. I want to thank many of our partners from the All of Us Research Program who are here. If you are working with the All of Us Research Program in any way, please raise your hand right now. So thank you all. All right, thank you all for the contribution and the work that you do. Exactly. And last night we had the honor and the privilege for one of the first times, I think it was one of the first times we actually had on the same panel, descendants of the legacy of Miss Henrietta Lacks. And we've heard the story of Miss Henrietta Lacks and how her HeLa cells have been used to advance science. But we also understand the transgressions and the medical mistrust, the justified medical mistrust that happened from that program as well. We also had Ms. Lily Head, a descendant from the United States Public Health Service study of untreated syphilis in the African American male, who was here, the study that took place in Tuskegee, Alabama. And sometimes we inappropriately call that study the Tuskegee experiment. And Ms. Head encouraged us last night to not call that the Tuskegee experiment, because by putting the emphasis on Tuskegee, you put the onus on a place that did not ask for that study to be done that way. So last night was about acknowledging the past and owning that. Today is about moving forward in the future. And I want to thank our panelists. And as Dr. Sodeke began to say, we're so fortunate to have Mr. Chris Williams here today. And from his days as a youth Sunday school teacher to becoming an ordained minister, to his years on the campus of Alabama State University, even now in the capacities as a former engagement lead and current community advisory board member of the All of Us Research Program Southern Network and Forge Ahead Center, Christopher Williams has a heart for people and a commitment to serve. Mr. Williams is a native of Gaston, Alabama, and knows firsthand the challenges many of our underserved communities face and is actively contributing his service to affect real change. Thank you all for your contribution today.
Good morning, everyone. Good morning, everyone. I'm trying to clear my throat. That was for me, the second one. It is indeed an honor and a privilege to be before you this morning. My name is Christopher Williams, as Dr. Kareem Watson has already communicated with you. I am an active member of the Community Advisory Board. Excuse me. And I am serving as moderator today. I am honored to do so. Just to give you a little background history on me, as it was already communicated, I was once an engagement lead for the All of Us program under a grant through the NIH program, and served in that capacity for a couple of years. Some of you I may have met as I covered several cities in the state of Alabama, but Tuskegee was definitely one of those cities that I covered. And in my tenure over that time, I got to engage with you all and get a better understanding. And as Dr. Watson said, one of the first things that I was taught was not to call it the Tuskegee experiment. That was a resonating message. If I didn't gain anything else, I knew that. And so that was so true. The onus is not on Tuskegee as a whole. It is a situation that is tragic in nature. However, I wanted to lift a couple of points from the ladies from last night, which was an awesome event. Let's give Ms. Head and Ms. Robinson a round of applause, as both have worked diligently to advance this situation for this community especially. One of the things that Ms. Head said last night, and I was taking notes, I actually have several pages of notes because they were dropping bombs left and right, if you will. But one of the things Ms. Head said last night was the challenge that her father gave her, which was though he cannot change what happened to him and the other participants in that situation, or that were engaged in that situation, she had a responsibility. We have a responsibility to affect the change, and I really appreciated that. That has been my mantra in my engagement with the All of Us program. Yes, things that have happened cannot be undone. However, we can affect the future of things. So that was a resonating point with me. And then Ms. Robinson definitely taught us all that it's important to ask why, to ask those questions, to go deeper than what is given to you, to know that there's more information behind the information that you've received. And both of those ladies really challenged us last night to pursue more. And that's what the All of Us program is about to me, pursuing more, knowing that we are not represented in the way that medicines are created, knowing that we're not effectively represented in the creation of medicine and the application thereof is a challenge. And so those were some highlights last night. And of course, Dr. Sodeke, as always, in his eloquence, gave us a few points to have respect when it comes to research, ethically, to make sure that the benefit of that research is communicated and carried out. And so we own those responsibilities. And so we thank Dr. Shodake for his contributions last night. And then Dr. Watson shared his personal testimony. And that's really an important piece of this whole process, to see yourself in the process and to know that what you're doing is part of your legacy, that you're affecting change that will affect your kids' kids, your grandkids, and thereon. But Dr. Watson shared a very touching testimony about his father, one that I can identify with. I lost my father to pancreatic cancer. I did not have a clue about research and what could be done in that time. But as I have gone and matriculated through this All of Us program and gained more insight, I want to know more. I have pursued more, and I will continue to pursue more so that my kids will have a better opportunity to receive the help that they need. So that's it for me in terms of my highlights from yesterday and my personal highlights. But we are going to move forward in the program. And we're going to introduce our first panelist for today, and that will be Dr. Deneah Maxwell-Stafford. Dr. Stafford is a native of Tuskegee and a product of the local school system. She's a 2007 graduate of the University of Alabama School of Medicine. She's a graduate of the Tuscaloosa Family Medicine Program, where she completed an additional year as an academic medical fellow. She holds employment with the Alabama Department of Public Health and Community Hospital, and she is a physician, owner of the Rama Health and Wellness Center here in Tuskegee. At this time, please receive Dr. Deneah Maxwell-Stafford.
Good morning. So I want to thank Mr. Williams because there were some missteps on the bio that was submitted to him, and so you saw me fix that 5 minutes ago, and he did a really good job with that. The reason I wanted to change that is because I'm proud to be from Tuskegee, I'm proud to be at home in Tuskegee, and I'm proud to be with you all here today. And so any chance that I get to be recognized, I make sure people know that I'm a native of Tuskegee, and I'm back in Tuskegee, and I'm glad to be here. So I don't have a formal presentation today, but I wanted to spend a few minutes just to talk with you before we move into the actual presentation. And one of the things that I was asked to speak about was the impact of COVID vaccination hesitancy, particularly in rural Alabama and the Alabama Black Belt. And so in order to do that, I started thinking about our COVID experience. And so briefly, I want to recap COVID experience both as a provider, as a family member of people who were hospitalized with COVID, and as a person in public health. I was able to see COVID from multiple dimensions. And so I want to just do a brief backtrack about COVID and how it impacted us here, and move into briefly the vaccine and the hesitancy issues surrounding that. I've had time lately to rethink COVID, to think about it, and if I had to describe the COVID experience, I would say it was surreal. There were times during COVID where it felt like we were watching a movie on TV, and surely this isn't the ending. Surely somebody's going to come in and save the day. But as we began to see more and more COVID cases, we really began to understand that this wasn't a movie. This was real, it was here, and it was impacting us. So I think the initial stage that many people moved through with COVID was initially denial. We saw reports on the news. We saw reports of what was happening overseas, particularly in China, but it really didn't affect us. It wasn't here. We're the United States. It's not going to get that bad. We'll just keep seeing, and we send a lot of prayers and well wishes overseas. Well then, as the numbers began to pick up overseas, we began to see COVID-related cases related to travel here in the United States. Again, we had this lack of sense of safety, that this is not coming here, it's only in the big communities, it's out in Seattle State, it's out, Washington State, it's out in California. we'll be okay. We're not a big epicenter for travel. But one of the things we began to see with COVID is that travel has made the world this small. We have people who were in China 1 week, and within 2 weeks, they were back on US soil. And while they may not have been to Alabama, they came through Atlanta. People from Atlanta came to Alabama. And so then we began to really see, this is real, it's here. What are we gonna do about it? So at some point, we came to a point of reckoning. As a community, as a healthcare community, we began to say, okay, these cases are here. I have about 3 people that I joke with every time I see them. They had COVID. We just didn't know what it was then. They were sick for 6 to 8 weeks. Nothing we did got them better. Thankfully, we just kept trying and they got through. But again, December of 2019, early January 2020, we just thought they had a prolonged respiratory illness. So as healthcare providers, we began to come to the realization, okay, COVID is here. It's not just in our bigger cities. It's not just in our bigger hospitals. It's not just in our bigger doctor's offices. It's here, and it's here in Macon County. So as we began to come to the realization, healthcare providers began to scramble. What are we going to do? How are we going to manage? COVID itself was new. There wasn't a lot of research. There wasn't a lot of data. A lot of what we knew about COVID came from trial and error, unfortunately. Scientists rushed to try to understand this virus. And let me pause and say, COVID-19 is a disease state, but I'll use that interchangeably when speaking about the SARS-CoV-2 virus. So the virus itself was new. We were looking to CDC, we were looking to the World Health Organization to say, what should we do with these patients when they come in? So as healthcare providers, we began to get the realization that this is here. We need to begin to organize and figure out how we manage it. Well, before that, we needed to figure out how to protect ourselves from it. Learning about PPE. When you talk about PPE and the lack of resources that were available in the community, I'm not sure many of you understand how the resources were limited for healthcare professionals. Break that down to healthcare professionals in rural Alabama without a lot of support from bigger infrastructures. We were scrambling. We were very fortunate that there were community organizations. Tuskegee University gifted local physicians with PPE because it wasn't just as simple as go out and buy it. There was none to be bought. And by this point, the prices had gone so high that if you were a solo practice, a small practice, you had to have money to buy this incredibly expensive PPE. So for us, that dawn of realization began to come early. For you all as the community, we began to see people get sick with COVID. Many of you had family members that became ill with COVID. Many of you began to see that the hospitals were overwhelmed. Doctors' offices were overwhelmed. A lot of doctors' offices faced issues of how do we keep the doors open? How do we keep our employees safe? How do we keep the patients that are coming into the building safe? Now, if you're a big operation, you've got a lot of excessive money, it was still a challenge. But to be a provider in a small town, it was even more of a challenge. One of the things that I saw personally was that some of the other offices closed. They just said, we're not seeing patients, go to the hospital. The hospitals were overrun. If you didn't have an oxygen requirement or need to be on a ventilator, they didn't have room for you. I'm very proud of the facilities in our area. I'm proud of my former employer, Prime Care Medical Center. We didn't close one day during the pandemic, and that took a lot of work. We lost employees. People were scared to come to work. Some of you came by, we got outside, we put up a tent, and we saw patients, and we did COVID testing. And so I'm very proud of my previous employer for allowing us to do that. But now as this realization continues to settle in, we've got access for patients to be seen. Testing, how are we going to test people? Testing was an issue from the top down. What I will say is that here in Alabama, we were fortunate. Whenever I asked the Department of Public Health for testing, they responded. Whenever other entities in our community asked for testing, they responded. One of the things that I'm most proud about of our community is that Macon County really stood up and took care of our own. I see Chi Eta Phi here. I see Mrs. Dunn here. These were just some of the groups that came together, pooled our resources, and provided testing on a fairly routine basis in Macon County. And so I think we should acknowledge the work of those organizations and similar organizations. So thank you. So as we move to this realization that COVID is here, it's killing people, we don't have a lot of great tools, we began to see more action steps. We saw action steps from local community organizations, just like I mentioned. We saw action from Tuskegee University, who partnered with many organizations to help supplement testing and PPE. Tuskegee University, along with myself, we sought out and were awarded a grant from the CDC and the Alabama Department of Public Health that truly helped us have testing available to anyone who needed it within our county. I don't think you all realize how blessed and fortunate we were to be one of the counties that people traveled to from Auburn, Montgomery. We had people from Georgia come here to get tested. And so that's a testament to how we stood up to save ourselves. So when we talk about action steps, public health went into action. And this is where some of the controversy started. Public health and CDC. Now, while you all were at home realizing, hey, COVID's here, it's bad, the other side of the team was realizing just how bad it was. What we were beginning to see were significant poor outcomes for people of color. This did not only apply to low socioeconomic status, but minority communities, minority populations were dying at devastating rates from COVID-19. And so CDC and public health saw this and said, okay, what can we do to help these communities? And so then you saw the push for testing, an information campaign, but when vaccines became available, one of the key pushes was to get vaccines into the communities that needed them most. Now, everyone needed a vaccine, but at the rate in which we were seeing people of color die, and also when we look at the resources in some of our minority-rich areas in the state of Alabama, the Department of Public Health said, we need to get vaccines to those communities. And this is where we begin to see the hesitancy, the distrust that came up. There were a lot of patients that said, this is just like Tuskegee. Why are they trying to give this to us? And every chance I had, I tried to explain to them, this is anti-Tuskegee. This is the exact opposite. This is a scenario where they see that our community is being affected disproportionately. They see that there's a potential life-saving or tool that will improve life. This is them saying, we didn't get it right with Tuskegee, but we want to do it differently this time around. Dr. Scott Harris is our public health officer. He was very open in trying to make people aware that this was the goal for public health for the increased push to get vaccines in communities of color. Whether or not you believe that vaccines work or not, the general consensus at the time and the science at the time showed that vaccines improved outcomes. And so the government this time actually did a better job of recognizing we didn't do well with Tuskegee, let's not make this a second episode. And so part of the push to really get vaccines into our community came from the government trying not to do what they had done before, was withhold life-saving or potentially life-saving treatment. As we moved into the vaccine phase, there were people who were easy adopters, sign me up, how many shots do you want me to get? There were others, well, I don't know about that. Let me see what happens. And for those, that's understandable. This was new science, appeared to be new science. Another issue is that people felt the vaccines were developed too quickly. But if you take some time to look at the history of the science behind the The platforms for the vaccine deliveries have been in the works for other applications for years. This was just a new application of data that was already there. And so what I would tell people is you don't want your cell phone to stay the same. Y'all go out and get the latest and the greatest iPhone, whatever, or whatever the phones are, because you want your phone to do new things. You want your phone to perform better. Same thing with science. We shouldn't want science to stay the same. It should transform and it should adapt to the needs of the people. And so, again, the seemingly rush to get the vaccine was only part of the story. The first half of the work had been done years before. And so as we move now through vaccines to treatment, we now have an approved treatment for COVID infection. The marketed name or the commercial name is Paxlovid. I can't remember the two individual drugs. Paxlovid is a medication that is having good result. People, again, are hesitant about that, but we're not hesitant to ask for a prescription for Ozempic or Mounjaro because we saw that it helps you lose weight on TikTok. And so we have to be consistent in our hesitancies. We don't need to pick and choose when we want to be seekers of science and experts, but be consistent across the board. Find you a healthcare professional that you trust. Find you someone that can help you have a dialogue about the information. Somewhere it says in the Bible, people perish for lack of knowledge. We've got the knowledge out here. We've got to be active participants in our health. We've got to listen past the conspiracy mumbo jumbo and make the decision that is best for you and your family. What I tell patients a lot, you're the boss of your body. I'm going to tell you what I think you should do, but ultimately, that's on you. And that's on you good or bad. So what I think I would just like to say is as we think about COVID-19, listen with a discerning ear. You all have resources available. Don't get so caught up on the loudest information that we don't listen to the factual information. And so with that, I'll stop and take direction from Mr. Williams.
We're gonna go ahead and go with our next panelist, and then we'll have panel discussion where you all will be able to ask Dr. Stafford and Dr. Fletcher questions. So I will go to the podium and introduce our next speaker. All right, and thank you again. A round of applause for Dr. Stafford. Very informative information. And now I have the pleasure of introducing our next panelist, Dr. Faith Fletcher. Dr. Fletcher is an assistant professor in the Center of Medical Ethics and Health Policy at Baylor College School of Medicine, a senior advisor to the Hastings Centers, and a Hastings Center Fellow. Drawing from diverse disciplines and methodologies in bioethics, public health, and behavioral science, her empirical research over the past decade has investigated pressing health concerns and inequities facing traditionally marginalized populations, namely Black women living with HIV. In her scholarship, she engages issues relating to reproductive health and autonomy, informed decision-making, structural stigma, and trustworthy in both research and healthcare settings. Her K01 award, funded through the NIH National Genomic Research Institute, uses stakeholder engagement approach to develop ethical practices and guidelines for engaging Deep South residents in genomic research. In collaboration with the Anti-Racism Task Force, Dr. Fletcher recently co-edited the Hastings Center special report entitled A Critical Moment in Bioethics, Reckoning with the Anti-Black Racism Through Intergenerational Dialogue. She is the former co-chair of the American Society for Bioethics and Humanities Race Affinity Group and the inaugural winner of the Dr. Clara Dupree Award in 2021. In recognition of vision and commitment to justice in bioethics, this award recognizes her excellence in anti-racism work in bioethics research, teaching, scholarship, and/or practice. Please receive Dr. Faith Fletcher.
Thank you so much. It's an honor to be here. Thank you, Dr. Williams, for that introduction, and an honor to share the stage with Dr. Maxwell-Stafford. So I'll start off by talking about a little bit about my experience and the lens that I bring in terms of advancing health equity. I'd like to highlight that I am actually a graduate of Tuskegee University, class of 2004. Oh, thanks. So it's good to be home. I'm also a product of Tuskegee University's National Center for Bioethics and Research in Healthcare. So it's an honor to be here as we're having conversations about bioethics and health equity. Many of my mentors and teachers are actually in the audience, so it's good to be home. Next slide. I'll highlight that I have an NIH, but this does not represent NIH's views or my college, Baylor College of Medicine. So thank you. Next slide. I'm sorry, I'm going to move this. It's a little hard to see. Is there a way that I can actually get, is there a better configuration for this? Because I don't have a screen in front of me. Or we turn the podium, possibly. Okay, thank you. I appreciate it. Thank you. So I'll reflect back to last night's conversation, a rich conversation, authentic conversation, the conversation that's needed to really advance health equity, especially around genetics equity, around research and clinical trials. So I want to highlight Dr. Kareem Watson, my colleague, when he said, we need more bioethicists addressing issues around the research process. I agree with this statement. I also argue that we need more bioethicists trained at the intersection of public health, health equity, with an interdisciplinary and intersectional lens to really advance health equity. Along with other scholars, we're asking critical questions to advance the field of bioethics and really to just transform the field as well. So how can bioethicists systematically and deliberately contribute to advancing health equity? What can institutions and organizations such as NIH and CDC do to really expand the bioethics pipeline so that we can train the next generation of bioethics scholars? And finally, how can we move towards a braver, broader, and a bolder bioethics, and one that really seeks to illuminate justice and to shed light on health injustices? Next slide, please. So the field of bioethics people that study bioethics are uniquely positioned to really advance health and healthcare equity. And I'll highlight a few ways that this is the case. A lot of us are familiar with IRB deliberation and IRB evaluation. We had some conversations about this. But it's also important when people are in healthcare settings and in clinics and you're having challenges and maybe there's some issues around family dynamics, people can ask for ethics consultations. So in a lot of my work, other colleagues, we're now having more conversations again about the role of bioethicists in advancing health equity. What can bioethicists do in healthcare settings, for instance, to address maternal mortality rates when people witness or feel that they're being discriminated against in healthcare settings? How can bioethicists come in to mediate and really to start to mitigate and highlight and document some of those health injustices? I also argue that bioethicists are uniquely positioned to engage in normative and empirical analyses to deepen conversations around structural and social inequity. So related to genetics equity, we can think about how can we mitigate potential harms and maximize benefits related to those participating in genomics research. Dr. Stephen Shadecki talks a lot about respect. So how can we demonstrate respect and equity in research processes? What does respect and equity look like from the perspectives of research participants? These are key questions and questions that bioethicists are involved in asking and answering. Next slide, please. So I want to reiterate that bioethicists are uniquely positioned to engage in normative and empirical analyses to deepen conversations around racial justice and health equity. Next slide. However, I argue that we bioethicists sometimes ask the wrong questions or even ask questions that lack relevance. And part of this issue is a lack of representation. The field of bioethics traditionally has not been racially and ethnically diverse, and many of us are working to, again, to expand the bioethics pipeline, to bring work, to bring stories, to bring narratives to the field of bioethics that really represent the voices and perspectives of communities that are marginalized or traditionally minoritized. Next slide, please. So part of this work, I just want to highlight that I do my work in community with other scholars, scholars of color, asking critical questions around racial and health injustice. We recently published an anti-racism special report through the Hastings Center, one of the oldest research institutes. It's a think tank, and this was actually a seminal report, the first report ever published by 4 Black editors. Also, a report that was developed in collaboration in community with 13 task force members. So instead of just developing scholarship, we sat around and we asked questions. What's missing from the field of bioethics? Whose voices are not represented? How can we engage community perspectives even in our scholarship? And some of these people might be familiar, such as Dr. Stephen Shadecki, Vince Bonham, Deputy Director, NHGRI, and other amazing scholars that have really helped to advance this work. Next slide, please. So drawing on last night's conversation, thinking about trust, distrust, mistrust, and shifting and reframing as it relates to trustworthiness. How can institutions become more trustworthy? What does it look like to be a trustworthy institution? These are questions that need to be examined from a normative as well as an empirical perspective. So I want to highlight one of the articles in the special report. Again, I think it really speaks to the conversation that we're having today. Dr. Yolanda Wilson, a Black philosopher, one of few Black philosophers nationally, well known for her work around health equity, health inequality. She poses the question, is trust enough? And I'll quote Dr. Wilson, "I begin with what is wrong with the question itself. I should say at the outset that what I have in mind is the largely public discourse around Black people's trust or distrust." And I'm just gonna skip down to the next for the interest of time. The sense that there is something wrong with Black people not only further disadvantages them, but also ignores the role that healthcare institutions have played and continue to play in fostering a climate of distrust. She also says, absent concerted effort to bring about a reasonably just society, efforts at building trust would not change the condition of many who are most profoundly affected by injustice. But she adds, such efforts might let responsible parties off the hook. So again, as we're having conversations and reframing, I argue that the field of bioethics, specifically Black bioethicists with lived experiences, with sensitivities to the issues of communities, should be involved in leading conversations around health and equity, should be working with communities, should be working with organizations and collaborating as we think about solutions. Next slide, please. So I highlight the field of bioethics needs a broader lens, and some work that I feel like is essential to this is engaging community and stakeholder groups as we're doing today, having conversations about minoritized populations, changing the language from distrust and mistrust to trustworthiness, centering the needs of populations that have been marginalized, and really highlighting the moral dilemmas. So Dr. Maxwell-Stafford talked about communities, and when we think about some of the dilemmas that communities that were underserved during the pandemic experienced, these are everyday dilemmas. These are not just dilemmas at the bedside. They are dilemmas that people experience as a result of structural and social and economic inequities. We also have to think about relevant research questions and topics that relate, again, to the needs of populations that experience health inequities. And in my work, I've really drawn on the perspectives of expert research participants, so individuals that have been enrolled, especially in longitudinal studies, have a lot to offer. They have a lot to offer in terms of how we conceptualize respect, justice, and other bioethical principles versus a top-down approach to bioethics principles. And finally, we have to think about disseminating our research findings in appropriate forums and training the next generation of bioethicists, and as well as the LC workforce, since there's integration between those two areas. Next slide, please. So I'm going to end with a tribute to Dr. Marion Grace Secundi, the first director of the National Center for Bioethics and Research in Healthcare at Tuskegee University. To our knowledge, she is also the first Black African-American to have a bioethics center that's federally funded. So Dr. Marion Grace Secundi really illuminated racial injustice. She was into mentoring. Actually, one of the first bioethics meetings that I attended, I learned later was the result of Dr. Marion Secundi's advocacy for training the next generation, making sure that young people had access to bioethics and health equity information. So I want to highlight Ms. Cynthia Wilson, who continues to ask critical questions, and someone that I also characterize as an ethicist. Again, part of this conversation is really thinking about who is an ethicist and who's not. And Dr. Wilson and I, over the years, have had these conversations where she's just like, you are a bioethicist. You're a bioethicist that has training in public health. So I've been able to own that title. But when you don't see people that represent the field that look like you feel like, well, this is not the field. So what we want to do is really expand bioethics scholarship so that people can pick up a bioethics report and say, hey, I can see myself in this work. We need people at the table. So I'll end with these two quotes from Dr. Cynthia Wilson as well as Dr. Stephen Shadecki. Marion became someone who pushed me to learn and would not take no for an answer. She taught me how to reconcile my differences of opinion with others' approaches to the same issues. She taught me to respect the decisions people make regarding their lives, even when all the information available contradicts those decisions. These conversations in which she patiently and calmly explained a person's right to die on their own terms helped me to survive my mother's death. And again, I want to thank Ms. Wilson for really contributing to this report. Her voice is valuable. Her work at Tuskegee, her work even in the archives really helps to expand and contribute to her broader bioethics. And finally, Dr. Stephen Shadecki commented, beneficiaries of her mentoring, Dr. Secundi, can continue her legacy by ensuring that people of color uphold a bioethics stance that expands the practice space. This can move us toward health equity, bringing out the best in all of us to alleviate unnecessary suffering and preventable pain. Dr. Secundi would ask us today to encourage one another to fight the good fight and to work for a better future for bioethics, at which time there will be no more us and them, only us. Next slide, please. And I'd like to highlight the next generation of bioethicists, some of my current mentees that are interested in work at the intersection of medicine, public health, philosophy, with diverse and intersectional interests. And again, this is what we need if we're thinking about expanding the bioethics workforce. So this is part of my legacy, and I am happy to be a part of Tuskegee's bioethics legacy. Thank you.
Much. Is this mic on? Thank you so much, Dr. Fletcher and Dr. Stafford. We are now going to transition to our panel discussion, and I wanted to open up the floor. We're going to go immediately to opening up the floor to allow you to pose your questions to these awesome women who have presented so eloquently today. Are there any questions? We have, I understand, it's my understanding, we have mics on both sides of the room. If you would, come up, present with your name, your association, and pose your question. I understand they were very thorough, but I'm sure there's some questions out there. I will pose a question to both ladies. And you both kind of alluded to this, but I would ask that you would share some examples that you have experienced with mistrust and skepticism towards research or clinical studies that led to hesitancy in other areas of medical care, if you can.
So I think when we look at basic preventative health measures, I still have patients that we have to counsel about the importance of a mammogram, about the importance of a pap smear, about the importance of a colonoscopy. And so it all resonates from this initial mistrust of the healthcare system at large. But what I try to encourage people to understand is that not doing those things doesn't affect the population at large. It affects you. It affects your family member. It affects your child that has to watch you go through a very much preventable illness. And so you just have to continue to meet people where they are, help people to understand the why behind the recommendations, but you also have to respect their autonomy if they decide not to do it. And so I think that's where medicine is shifting from this very paternalistic, do it because I told you to do it because I'm the doctor, to look, this is what's recommended, this is what is advised. My recommendation is that you do this, what do you want to do? And understand that we will disagree. And it's okay to disagree, but my goal is to make sure that you're making an informed decision and that realizing at the end of the day, that decision is yours to make.
That's an excellent example. And I'll just add, from a research perspective in my work with Black women living with HIV and African-American adolescents around PrEP or pre-exposure prophylaxis, I'll say that sometimes we misattribute distrust, and a lot of times people are just wanting more information, more education. So again, shifting the conversation, I think we need to think more about who are the trustworthy sources, and you're just completely alluding to that. People need information and they're able to get that from you. So I think the more conversations we have, the more people in leadership in terms of medicine, public health, and bioethics, it will really help to expand and build this culture of trustworthiness and removing the responsibility from individuals to be more trusting of medical and public health and other establishments.
Thank you, ladies. Good. Let's give them a round of applause. Has anyone stepped to the mics? I can barely see this side. Again, if you have a question, feel free to step to the microphone. I'm going to allude to a question that Dr. Cynthia Wilson posed last night, and that is about comprehension. As clinicians, how do you all address the population who is unable to conceptualize bioethics or any other medical terminology or what have you? What are some of the measures that we take, that you all take, to address those kind of situations?
So as a researcher, and I think Dr. Watson talked about this last night, thinking about more innovative methods of informed consent processes. So in research, we have something called the talk-back method. So you might present information and then you ask a person, what did you hear? Similar to cognitive interviewing, how can you interpret that information? So I think the more we have community stakeholders and other people that are potential research participants or existing research participants to help us to develop protocols that are more structurally appropriate and really, again, address the needs of populations. I think that's the innovation. That's where we need to move, and this is what the conversation is about today. So, yeah.
Okay.
I think we need to learn how to talk to people. That is not dependent upon your status, that is not dependent upon your title, that is not dependent upon anything. There's a book, Everything I Need to Know I Learned in Kindergarten or something like that, where you learn how to say please and thank you, you learn how to talk to people. I think sometimes as we move through different stages in careers, whatever it may be, medicine, education, if you're an instructor, academics, we sometimes think that we have to use all of the big words and the big terms all of the time. And I think that your patients want to know that you can use those, but they also want to know that you can explain this thing in the terms of a football game if you need to. And so I think taking a moment to know your audience, know who you're speaking to. When I go to the doctor, I don't want you to talk to me like I'm Dr. Anybody. I want you to talk to me like I'm a patient, because in that moment, I am a patient. I don't disclose who I am when I go to the doctor. I want you to treat me just like everybody else that you see. And so when you engage with patients or whatever your affiliation is, you have to know who you're talking to. One of the things that Dr. Fletcher mentioned was kind of saying, well, what did you hear? Every visit, I'll say, now what are you going to, or most visits, what are you going to go home and tell your wife I said? And they'll give me that recap, and I'm like, did we just spend the last 15 minutes talking about nothing? And so sometimes, even though you've put a message out, you have to have some feedback from time to time as to what was heard. And I think when we look at medical errors, a lot of times we see medical errors because there was a disconnect between what the direction was given and what the person interpreted. And so we just have to work on that. And that's among all fields. If you're going to the bank, if you're going to pay the water bill, people need to know how to talk to people. And I think that that helps with gauging, or helps have more effective communication.
And I love that. And I think part of what we need to do more of is integrating more health communications into our work. One example from research studies, sometimes we ask who is best suited to deliver the message? Who would you like to facilitate the conversation? And I know as a Black scholar, there are times where people are like, oh, you should go out and do this focus group. And when I lived in Chicago, I learned from the young people, they're like, no, 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 no. We don't want you to be our facilitator, our focus group. We want that person. She's cooler, she's hipper, she's from Chicago. So again, thinking about even the complexities and the nuances of Black people talking and engaging with other Black people. There may be geographic differences. There might be some social and structural differences. So we have to be more aware to those sensitivities and not always just put a Black person in a research study with other Black participants. There's a lot more work that needs to be done around that. But again, doing empirical work to understand who should be there, who should be leading, who should be facilitating, who should be delivering the messages to the community.
Thank you, Dr. Fletcher. I'm going to segue that question. That was one point that I think addresses my next question, which is, what are some of the challenges researchers of color face when elevating their work?
We don't have that much time, do we? I think I'm standing between people and lunch. So I think it's being the one sometimes in an environment that the only one. And I can say, and I'll focus more on the positive, the pandemic allowed the opportunity for us to do a lot of work virtually. And the special report was really born out of virtual engagement and interaction. I was able to work with colleagues nationally from different places. I don't think we would have really pursued that opportunity or even thought about the possibilities of engaging in that way. Sometimes we're physically just thinking about whose office is next to me, who can I work. So it has really expanded and changed the way that I do my work in community. I'm a lot more selective now in terms of who I work with. I want to make sure that I work with people that align with my perspective and my ethos. I'm not going to publish a paper with someone that might publish a paper on something else that misaligns, because that really, it's important that community people and other people can trust that I'm focused and really committed to social justice. So I think there are a lot of challenges, but the more we engage with one another and do work that's important to us and important to community, I feel much more elevated and amplifying the voices of other scholars of color. We have to do more of that. So I can do an entire presentation and not talk about my work, but just talk about the work of Dr. Wilson, or Dr. Stephen Shadecki, or Dr. Shantice Allen. We have to continue to amplify and elevate other scholars of color and remind people to really cite our work. It exists, it's here, we're doing it. People have been doing it for decades. Health equity work is not new. We just have to really reach back and acknowledge the scholarship, the existing work that's there.
Thank you. Dr. Fletcher, we do have a question from the audience. Please introduce yourself and ask your question.
Hi, everyone. everyone. I'm Ariana Thomas. I'm a nursing student at Tuskegee University, senior, graduating in May. And my question is, being in a rural community, are there any benefits to patient care out here?
So give me a little bit more, any benefits as far as?
Like, I know there are a lot of challenges to being in a rural community when it does come to healthcare, like access, but are there any benefits?
There are a multitude of benefits of being in a rural community. There are a multitude of challenges, but we're able to overcome those. I think and I'm gonna tell on myself now so people will know, but one of the things I like about being in this community and living in this community, I can see people day to day. They may not always see me, or they may not always see where I am, but I see them. I see when Miss So-and-so is limping a little bit and hasn't been. I see when we may be oh so sick, but I glimpsed you at the ball game and you were oh so well. So, those are some of the intangible benefits of being in a small community. People appreciate you. Doesn't mean people always agree with you. People get upset. But I try to treat people how I want to be treated, even if that's not how you want me to treat you. And so, but people are appreciative. People, they feel like they have a resource, and they do for the most part. There are a lot of people that I'm not their physician, but if we're in certain activities, they may pose a basic question, and sometimes it's helpful to say, hey, maybe you need to ask about this, that, and the other. Just being in a community where people want you to succeed. And again, I'm not naive enough to think that everyone is my biggest cheerleader, but there are a lot of people here that I certainly appreciate for allowing me to be successful. So I think when you talk about the benefits, when you look at those benefits, you can't really put a cost or a measure on those. Now, financially, there are some hardships with practicing in a rural area, but there are a lot of caveats. There are a lot of ways or programs that you can apply for that help offset some of those financial limitations. So I encourage people to think about it. You have to have a little bit of a tough skin to do it, but I don't think I would do anything differently than what I do now.
Thank you.
Do we have another question coming? I think I see someone. Yes.
My name is Tanya Bell. I'm with the Wellness Coalition. We have a table in the back, so on the break, please come by and see us. First of all, Dr. Deneah, Mama, I saw you coming out of the bathroom. I said, I think that's, but I didn't want to speak because I wasn't sure. But I first want to say I'm super proud of you. I'm sitting here smiling, just as your accomplishments. I'm a little older than she is, but we did go to school together. What made you come back home? Simple question.
Oh, wow. So it's a simple question. I always knew. So if you're from here and you remember Adams Nursery or Little Lamb Nursery, I can remember clearly one of my teachers was Miss Eccles. And I remember her asking me what I was going to be. Now, Adams Nursery was a pre-K type facility. And I told her I was going to be a doctor. And until, she would always, over the years, that girl said she was going to be a doctor. And so I fully believe that it was something that I was destined to do. I think it was put in me even before I came. But as far as coming back home, that was just always my plan. I think that sometimes when we are from rural areas, we need to understand that it's not always woe is us, what don't we have, but we need to celebrate and acknowledge the things that we do have. Tuskegee was rich in history, rich in culture, rich in activities for kids to do growing up that mimicked Auburn and Montgomery. And so as we got older, we saw that some of those things went away. Some of that has to do with our economy, but some of that has to do with parents not being the parents that we were fortunate to have that made activities for us. And so as I got to go to school, got to do things, I wanted to come back home and be a part of what some of the people in this room created for me while I was growing up. So, like I say, there are challenges, but the good times far outweigh the bad. And so it's just been I'm very pleased with the decision, and it's just all worked out. So I think that it was meant for me to go and come back home.
Awesome. Thank you.
Thank you. Is there anyone any other questions? Or I'll ask one more question. Considering the impact of the pandemic, and Dr. Stafford did allude to it in her presentation, there was a major setback for many health facilities. And, now that we are quote unquote opening back up to some degree, where do you all see healthcare advancing, stagnant, or improving now that we're quote unquote opening back up? And what are some of the things that you all think that we may need to do to reestablish the amount of trust that we had that was minimal, and to advance it going forward?
So I think that one of the benefits, and Dr. Fletcher alluded to it for me personally, was the adoption of more telehealth, telemedicine. Now, that doesn't come as easily as people think when it's just give me a telehealth visit. There's a lot on the back end of that, with your insurance companies not wanting to compensate for all types of visits. But I think it opened up, for me being in a small town, a means by which I'm going to actively pursue how can we do more of that. At the same time, one of the challenges that it opened up was the need for better internet access. And I know that's one of the projects that Mrs. Dunn has been working on, because we have patients that don't live in the city limits. You live in the city limits, you don't always have the best internet service. But we have patients that live out in the county that barely get a cell phone signal, much less a signal strong enough to do a video visit for healthcare. And so I think looking at ways in which we can improve that. One of the things that we had to trial recently was, can we bring the patients to a location that has access and do the telemedicine visit from there. And we were able to trial that recently, and so that has potential. If we can get patients from the county to come to a health department or another facility and have them set up where the provider can then telemed in to that location, I think that has great potential for us, especially in rural Alabama. So I think it was an opportunity on an individual level to see how I can incorporate more of that. But it also builds upon some work already being done with telemedicine, specifically as it relates to kidney failure and dialysis. And so when we look at the rates of dialysis and who's needing dialysis, again, disproportionately in our Black Belt counties where we don't have strong broadband signal or strong infrastructure for telemedicine. So I think that's just one area that I think it showed an area where we can incorporate this more, but it also highlights an area where we need to continue to do work to get services to our patients, our family members that are in these rural areas.
Yeah, and I'll just add that it just really highlights the need for better systems and discipline integration. So more integration of public health, medicine, as well as bioethics. And an example of this is when we're thinking about structural racism and anti-Black racism even. There's more awareness, there's more public awareness around it. So that really helps to make the case for better systems of collecting and really documenting racism and anti-Black racism in healthcare settings. So again, I think the more data we have, the more evidence we have, the better systems we can start to develop. Collecting more demographic data in healthcare settings will really help to move us towards better healthcare generally. So, yeah.
Thank you. This concludes our session, our panel discussion for this particular segment, and we're going to transition into our lunch. We want to thank Dr. Fletcher and Dr. Stafford for their presentations and addressing our questions. One more round of applause for them. And it was my honor to serve as your moderator for this particular session. I thank you for your patience, and we look forward to pushing the envelope even further with the All of Us program and other programs such as this. Is someone going to bless the food, or do I need to bless the food? Or oh, Pastor Jones.
Excellent. If you all don't mind, we'll bless the food from here, and then you can just go on over to the table, and we have the meals packaged. Let us pray. Father, thank you. Thank you for this fellowship. Thank you for the impartation of wisdom. Thank you for information shared today. Now, Lord, we ask that you bless the food that we're about to receive. Bless the fellowship that we will continue to enjoy. We ask it all in Jesus' name. Amen.